welcome everybody to this special version of PMP Pals Hope Zoom. As you're entering the waiting room here, we are muting everybody since we have a large group today and we have a formal presentation. So bear with us as we continue to admit some people to the presentation.
Good to see so many faces today. Welcome, everybody. Yeah, I see Kelly Beckerly bringing up the rear. Good to see her.
Kelly,
there's a lot of people going to be interested to see her.
I think we'll go ahead and get started here. So good morning, everyone. My name's Adele Jason. I'm the Vice President of PMP Pals and a almost 10-year survivor. And then Chris?
Well, I'm Chris Piekarski. I'm the president of PMP Pals. I'm a 16-year survivor, and I'm recovering now from my second HIPEC. I'm just 1 month out, and happy to see everybody and super excited to have Dr. Bartlett and Dr. Wagner here today.
Charmaine in Austin, Texas. I'm on the board too, and I'm a 23-year survivor. I had my HIPEC surgery 12 years ago with Dr. Sugar Baker.
Hi, everyone. Welcome. James Caldwell from Northern Ireland. I'm a 7-year survivor of a high-grade appendix cancer, and I'm also an admin on the Facebook group.
Good morning, everybody. My name is Connie. My husband is a 5.5-year survivor. I'm in South Florida. I'm one of the volunteers and caregivers.
Hey, for those that might be new to our session today, PMP Pals is the world's oldest global volunteer-run organization that gives hope to patients and caregivers fighting appendix cancer, or PMP. We provide forums for fellowship and support, but we are not licensed to provide medical advice. So we do encourage everyone to seek their qualified licensed physicians to develop your individual treatment plans. Today is a physician presentation, actually plural. We have two esteemed surgeons with us, and so you may be seeing data or seeing graphics that might be a little bit scary. When you participate in our Hope Zoom calls, your identity and health might be shared with the public. You're allowed to hide your image, change your name. We do our best to anonymize participants, but you need to be aware that we might not be able to completely anonymize everyone. And by participating, you're giving your permission to share your likeness. As far as Hope Zoom today, again, welcome to our new people, welcome to our returning people. You can participate by sharing or listening. You're never obligated to talk, although today is a formal presentation. Please use the chat feature. As Chris mentioned earlier, we've muted everyone for the sake of eliminating noise during the presentation. And we hope you can stay with us as long as you can, but if you need to leave, feel free to do so. And please stay connected with us throughout the week, through our website, our Facebook page, or our Instagram. It is my great pleasure to introduce Dr. Bartlett, a name familiar to many of you, and for me personally, Dr. Bartlett, my surgeon, when I had my surgery almost 10 years ago. Dr. Bartlett is the chair of the Allegheny Health Network Cancer Institute in Pittsburgh, and a pioneer in the treatment of PMP and other peritoneal disease, and a prolific researcher. He's an internationally recognized cancer surgeon, past president of the Society of Surgical Oncology. And as those of you that were able to join us for our tribute to Gabriella Graham, our founder, Dr. Gabriella was a patient and friend to Dr. Bartlett, and there was mutual respect and learning on both sides, and so we very, very much appreciate your comments. So with that, I will turn it over to Dr. Bartlett to kick off the presentation.
Great, thank you. I do appreciate this opportunity, and I can't say enough about what PMP has done, or PMP Pals has done for this disease and for so many patients over so many years. So it's great to have to be a part of this and to see what you all are doing. It's great to see so many familiar faces. And I know that, this is a tough disease, and the reason that you're all dedicated to this is because you've been touched by it. And, I've always said that peritoneal abdominal tumors really represent one of the most difficult types of cancers that anybody has to deal with. So cancer is bad enough, but dealing with abdominal tumors and carcinomatosis is really, really challenging. And so, what you all do and what you do for each other, I think is extremely important. I've been working on this for 25 years, over 25 years now. Started at the National Cancer Institute back in 1995, and then moved to the University of Pittsburgh in 2001, and continued the program in peritoneal surgery throughout my time at the University of Pittsburgh, and then recently transitioned here to the Allegheny Health Network. And I think throughout that time, there have been a few things that I've been working on that we can talk about a little bit today. One is kind of educating, we learned over time how to do the operations, how to do them well, kind of how to understand the disease and the biology of the disease. So we knew what we could get away with, what was reasonable, what was the right thing to do for patients. And we're not always making the perfect decisions, but that's such a big part of what we do as surgeons, is really try to make the right decisions for the right patients to help out. So a lot of it was learning that process, and then educating as many people as we can across the country, across the world, to help with this horrible disease. And I think we started the Regional Cancer Therapies meeting back in 2001 when I moved to the University of Pittsburgh, and that has really grown and developed over time. And we've really appreciated PMP PAL's participation in that. But the real point of that was to spread kind of the education and research around this disease throughout the country. And it really has done that. Over time, we've seen over 200 programs in peritoneal surgery across the United States. When I left the National Cancer Institute, there was really only 5 designated programs. And so that kind of explosion over the last 20 years is really astounding. I think, what we perhaps haven't done as well at is moving the field forward with innovative therapies. And so part of what we wanted to cover today was, what's next? HIPEC has been around a long time, and a lot of people have benefited from it and will continue to benefit from it. But what's next, and what can we do that's easier on patients, and what kind of therapies can we look to towards the future? And so that's what I wanted to discuss today. In addition, I think it's extremely important to understand kind of what goes into a peritoneal surgery program. And this, is where you can seek the specialty expertise. You can be sure that all aspects of your care, from the, exercise oncology, integrative medicine, palliative care, pain management, and aggressive therapy, clinical trials, where we put all of that together into a program to really benefit the patients. And these are the programs that you're seeing develop across the country. But I thought it would be nice to kind of highlight that the program that is really required to advance the care of patients with peritoneal metastases. And I've been very fortunate. So I've moved from the University of Pittsburgh, and we have a great team of peritoneal surgeons at the University of Pittsburgh that still remain there. I moved and recruited a couple of people to come with me, and so we're still in Pittsburgh. We're at the Allegheny Health Network, and we have developed a program here that I think, thanks to Dr. Wagner, is really state of the art. And I've learned a little bit over the years. So I really, working with Dr. Wagner, I think we've put together a good program. And so I wanted him to kind of start and just give an overview of what peritoneal program is, kind of how it stands out, and what our goals are in the overall management of peritoneal surgery and peritoneal carcinomatosis. And then I was going to touch on what I've been doing in the laboratory and in the clinics over the last 25 years to try to come up with better therapies. And so that'll be very specific to the research that I've been doing. But certainly at the end of this, we'll open it up to questions so that any research that you've heard about or anything that you'd like to discuss, would be happy to address. And because I've been to every meeting, I think that's ever been had around peritoneal surgery and research, hopefully I can weigh in on these things and help you out. So first, I'm going to turn it over to Dr. Wagner. Dr. Wagner trained with me at the University of Pittsburgh. He did his his undergrad there, and then went to medical school at Harvard and did his surgical training at Cornell. Uniquely, he's, in addition to an accomplished surgical oncologist, also a pathologist, and so trained in both pathology and surgical oncology. And then has developed an interest over time in complex abdominal surgeries and peritoneal metastases. And so it was exciting as I transitioned to recruit Dr. Wagner back to Pittsburgh and have him lead this program in Pittsburgh. So I'll turn it over to you, Patrick.
Thank you. I'll take a few minutes to introduce myself, and I will tell you right up front that I'm on my porch, and you may hear some chickens or dogs or the stray boy running back and forth with the soccer ball behind me. So I'll try not to get too distracted by that. So as Dr. Bartlett said, I had done my fellowship at UPMC, and then I transitioned to the Shenandoah Valley of Virginia to start a community practice in a vibrant, mostly rural community, and did a lot of surgery. And probably about a year ago, started to look for other opportunities where I could get back into research and utilize some of those skills. And around the same time, Dr. Bartlett announced his transition to Allegheny Health Network. So I recognized that as an opportunity really to go start something new again, and also to have an opportunity to work to replace or update the treatment of peritoneal surface with things that are more, hopefully, innovative and effective. So when you start something new, you have a chance to ask questions like, what should a peritoneal surface center look like? The one that we've built, we were able to build from scratch because there was not a center there already. So it gave us a chance to leverage, most importantly, the experience that Dr. Bartlett and others have had over decades of taking care of patients in these conditions, as well as modern concepts of uniform practice, patient-centered care, and obviously the translational research that we're very excited about. So when we were thinking about what it should look like, I think it's important to sort of think about three main things. Firstly, solutions. As individuals on this call don't really need a reminder, patients with advanced peritoneal disease are often given few options, if any at all, and that happens a lot where there might be unfamiliarity with the disease processes or unfamiliarity with the options that are out there. And so many patients are never really presented with solutions that exist today and are considered standard practice or standard of care. So that's an important part of what a peritoneal surface center should offer. The second is hope. Hope in this context equals research and development and innovation to move the field beyond where it is today. And then thirdly, and this is often or can be the most important aspect for a particular patient or a given patient, is to acknowledge when we've got to the point where we have unfortunately nothing to offer that we are able to think about as curative for a treatment, so to speak, that we are providing comfort and helping families and patients transition through that process. I'll jump ahead here to the solutions part of this. Obviously, this group is very familiar with the concept of cytoreductive surgery and heated peritoneal chemotherapy. There's been untold numbers of very large series describing the outcomes with this technique. There's a lot of debate, as you all know, over exactly how to do the operation, which agents to use in the chemotherapy context. And I would say that we have refined this technique and wrung out of it just about everything that we can get down to elements of what dose of medication to use for how long, and really just kind of push this to the very limit of how far it can go. And honestly, not much has changed other than sort of the details, and certainly the surgical outcomes are better, and we're better at taking care of patients before and after surgery than we used to. But we're not really doing anything novel in terms of the agents or what's given to patients. The workhorse agents that are used now are not new. They are many decades in age. And that's in spite of so many advances in understanding cancer biology and developing targeted agents and newer agents for many other diseases. This is outcome data from a recent randomized trial many of you may be familiar with. This was a European study of, and this was in colorectal cancer, not appendiceal, but I think the same principles largely hold. In the one arm, it was just debulking or cytoreductive surgery, and in the other arm was cytoreductive surgery plus HIPEC. And there was a lot of debate over the details of the HIPEC, but really I just want to focus on the big picture here, which is that even in the best of hands, with the best perioperative care that we have available and all of the knowledge that we've acquired over the years with this, I think there's really two main things to take away from this. On the curve on the left are the overall survival curves. So in this particular study, it did not appear that there was a difference with or without HIPEC. It looks like the cytoreductive surgery or debulking did most of the work, but probably the biggest result of this entire experiment was relatively surprising and shocking numbers to some folks about the overall survival. And in this series, almost 50% at 4 years, 40% at 5 years, patients with carcinomatosis from colorectal cancer. And historical series, this would be 0% survival. So whether or not the HIPEC adds a lot, we have yet to define, but with modern systemic chemotherapy and aggressive surgical debulking, these are the results that we're obtaining in modern times. On the right side, however, is recurrence-free survival. And unfortunately, even though patients are living longer, over time, the patients are recurring, and that's what these curves represent, is sort of the percentage of patients that are disease-free over time. And it drops. And even though the patients are surviving for many years in many cases, the reality is that recurrence is frequent and really the rule rather than the exception, and happens at an average of about a year or 18 months, which is certainly better than historical results, but nowhere close to where we want to be. So when I decided to come back to Pittsburgh and rejoin the research efforts in this field, I think we had some very honest and frank conversations about, where things are now and where we'd like to see them. And I don't think we really wanted to simply build a HIPEC center or a HIPEC program. We wanted to start with that because that's the best thing that we have right now. That's the standard of care, but immediately pivot to thinking about what comes next and how to do something that's more effective, less invasive, and smarter, and takes into account everything that we've learned about cancer, and specifically the immune system and its ability to fight cancers over the past decades. Our knowledge has revolutionized our understanding, but there's little tangible outcomes yet in terms of concrete methods to treat a cancer like this. And the formatting has changed here, unfortunately, because of the technical snags, but this is basically and you're not going to be able to read the words, but I'll read them for you. This is what we would sort of think of as our process of patient intake and care in a modern program. So it's not just about the operation and the immediate care around the surgery, but this starts with selection and evaluation of patients. And that has to be a formalized intake process with a lot of attention to navigation. And really, in many cases of this nature, there's a lot of records to go through and just kind of a lot of work to do to understand how patients have worked through the system, what's already been done, what's already been tried for them. And even just compiling those kinds of records can be a full-time job. Once we're able to evaluate patients and gather their records and see them, we have to move on at that point to a multidisciplinary evaluation. It's really not enough just to be seen by one specialist. There's a lot of questions about systemic therapy. There may be a lot of questions about other forms of therapy that are new and emerging. We need to engage our pathologists. We need to engage our radiologists. And really, it takes an entire team of specialists. Even if it just boils down to a surgeon doing an operation, there's an army of specialists behind that decision making. And our program is set up so that every patient gets that behind the scenes. Even though you may only meet the surgeon, you're being evaluated by a much bigger group of specialists and experts behind the scenes. I think we've made a lot of ground over time in understanding how to get patients ready for surgery. I think in the past, patients were moved very quickly into the operating room, and now we take a bit more time to consider how we can make it safer. And a lot of that involves operating technique, but a lot of it involves careful attention to the details of the patient's medical background, what medications they may be on, what kind of shape their heart and lungs, liver, kidneys are in, et cetera, and really tailoring an optimization protocol for a given patient. A huge part of that in carcinomatosis or PMP would be nutrition. And so having a nutrition team engaged from the very beginning of this process to help us prepare for an operation is vital. Another element is what you would consider prehabilitation or physical therapy, et cetera, happening before surgery to engage the patient and family members and caregivers up front in terms of physical recovery after a big operation. I would say the next arm of this is uniformity with our documentation and recovery pathways. We've learned so much about this over time that we can say with good evidence which practices work better than others to advance patients through their recovery faster. We have learned much over time about optimizing workflows so that, for example, post-op orders are triggered and almost automatic and can be altered as appropriate, but that is all thought out and planned ahead of time so that patients are getting the same high standard of care every time we do an operation like this. And then lastly, in this cycle is a continuous QA and review of best practices, which we integrate not only our own internal results, but also outcomes and results from other centers from which we can derive insights into how to do it better. So that kind of leads back to the beginning of the cycle where it feeds into our process that's continuously improved in that regard. Outreach is a big part of this. I mentioned patient navigation, and we try to take that to kind of a new level here because many patients, as you all know, have to travel long distances to get modern care for this disease. So it's not like other cancers where patients go to their local cancer center or somewhere close to home and receive basic standard of care. Here, the standard of care is specialized. It's by definition not available to most patients in close proximity of their home. So that requires a different level of attention and a different level of engagement with patients and family members right up front. And it almost requires a concierge level of service to bring patients at least by telephone in for an evaluation, just to sort out what they've been through, what they're going through, where they are with their disease process, and get films, get records, all of that sent so that we can begin to make sense of a complex case. We've worked through a lot of bugs with second opinion clinics, and in the era of COVID, we've really leveraged telehealth to help with this. As you all know very well, traveling long distances while struggling or dealing with a disease process like carcinomatosis is a burden on patients. So the more of this we can do remotely, the better. And even something as simple as setting up a dedicated phone line for connection with our experts, which we have developed, and it really just gives patients one point of contact to get plugged in. And once we have a connection with a patient, then we can wrap our entire team around them and help get what we need and get them what they need to see what is available. When it comes to hope for patients with complex cancers like peritoneal surface disease, without research, we're just stuck. We're really just sort of stuck right where we are, which is better than it used to be, but nowhere near where we want it to be. And there's all kinds of different forms of research, whether it's down into the molecules and looking at the causes of a cancer, or trying to identify new or novel targets for a cancer, and then taking that into the clinic or into the operating room and adapting that knowledge into new forms of treatment. And then even into other forms of research like outcomes research, where there's really, you're just analyzing big data sets and trying to assess what worked and what didn't. And then even another echelon of the big picture, which is a field of research into value-based care and seeing how this type of treatment fits into the broader healthcare system, and even thinking about kind of a national or nationwide assessment of where things are and how to concentrate the resources in the best places to get patients what they need. So we've been fortunate, even in a very short amount of time, to hit on all of those cylinders, and are extremely excited about research projects that we have underway, and again, along that entire spectrum. This is just a couple pictures that I took on my phone in my lab, which we set up over the past 6 or 9 months. And as Dr. Bartlett mentioned, I was trained as a pathologist as well. So we've kind of set up a parallel process to handle tissue for research purposes, which really gives us a massive head start on this process, because we can take the tissue straight from the operating room up to our lab. And of course, some of it goes to the regular lab and is analyzed by the pathologists for the clinical needs in a given case. But what isn't used for that purpose is available to be taken directly right up to the lab right that minute, and can be processed and put into a format where biomarkers can be looked at. And really any research question that you can possibly imagine looking at the tissues can be answered right upstairs from the operating room. So it's very, very exciting, and really couldn't be more excited about the possibilities here. We have a research protocol underway to develop a comprehensive understanding of the peritoneal immune system in carcinomatosis. It's not that hasn't been done already, but as time goes by, we learn so much more about the immune system now. The studies that were done 5 years ago, 10 years ago, or even 1 or 2 years ago are almost out of date. There are so many new questions and new facets of understanding about the immune system. And the peritoneal cavity is different than other areas of the body. You may have heard of a blood-brain barrier, or how the central nervous system is shielded from the immune system. And in some ways, the peritoneal cavity is not shielded from the immune system, but it has different types of T cells in it. It has different types of immune cells and a different set of cytokines, which are which are essentially the hormones of the immune system that are used to communicate cell to cell. And so this specialized environment for the immune system, we really have just scratched the surface of understanding how it works really in normal circumstances, let alone in cancer. So I think that we will learn a lot. And the more that we know, the more we can learn, because we are asking smarter questions as time goes on. Another area of research that I'm very excited about is looking at the impact of the microbiome on the immune response to colorectal cancer and other digestive cancers. The microbiome basically is defined as all the microorganisms that live in your gut or on your skin or in your lungs, really all over your body. There's a statistic that there's about 100 trillion bacterial cells in your intestines right now, and that is about 10 times more cells than your entire body has. In other words, you have 10 times as many bacterial cells in your body as you do human cells. That astounding figure just opens up lots of questions about how those bacteria affect the immune system. And we believe that the way the gut bacteria or the microbiome bacteria and viruses and fungi, there's other kinds of organisms there, but the way that they interact with the immune system may have something to say about how a given tumor is perceived by the immune system. And that we know directly translates into prognosis and outcomes with cancer. The better the immune system is at identifying a cancer as foreign to your body, the more successful the immune system will be in eliminating it. So this is an active project that we have going in my lab as well. And we have a collaboration with between our health network and the Johns Hopkins School of Medicine to foster joint projects of this kind. So that's very exciting for us as well. And then lastly, the last thing that I was going to touch on, and I think Dr. Bartlett is going to talk about this a bit more, so I'll go through it relatively quickly. But the concept of clinical trials and having them available to any patient who walks into our center or engages our center in their care should have something available to them in terms of a clinical trial of something new or innovative. It's not that we want to downplay the role of standard therapies, but we just want to acknowledge their limitations and move to something better or more effective. And so really my vision would be that we have something to offer every patient who comes to see us in terms of a clinical trial of something innovative. And of course, some patients may choose to receive standard of care, but at least they have a choice. At least they have something to think about or sign up for if they're interested. One of the things that we hope to get off the ground over the next few months, and probably this will be many years in the making, but right off the bat, we can start to look at chemicals and in fact, some of which are derived from bacteria that can be injected into tumors or injected into the peritoneal cavity to alert the immune system that there is a problem or something foreign. Tumors are very good at hiding from the immune system. And so we think that, or we believe, and in some cases have shown that alerting the immune system to the tumor by injecting or stimulating it with something that comes from a foreign organism can just basically wake the immune system up. It's like smoke to the immune system. It signals that there's a problem, even though the tumor had become very good at hiding. It spurs the immune system to recognize the tumor as foreign and can leverage that either with the abilities of the immune system alone or in combination with chemotherapy or systemic therapy agents that also help unmask the immune system's ability to fight tumors. So there's a number of these, and I have been excited recently to just read about what's out there and learn more as time goes on. But we can inject these agents directly into tumors, and there are other vehicles, liposomes, which is essentially like a Trojan horse technique to get agents like this into cells. And there are all kinds of nanoparticles and carbon tubes and magnetic nanoparticles and things that I've heard very little about in terms of the engineering, but I'm very excited to get these into clinical trials as time goes on. And then I'll just skip directly to the last of this, which I know you're going to hear about more from Dr. Bartlett, but we're also very excited about getting oncolytic viruses into this mix of potential new agents to use. A big part of Dr. Bartlett's research career has been developing oncolytic viruses, which are cancer-fighting viruses for use in clinical scenarios. And that brings me to this image, which really just puts my vision of where we are right now out there for you all, which is that we have so many weapons now. We have so much more understanding about cancer, peritoneal cancer, other cancers, and the immune system. And it's just getting that last yard that's the hardest. It's the hardest thing to do, just to get it over the finish line. All of this promise and all of this knowledge and all of the work up until now, and yet we're still using 70-year-old chemotherapy agents. That to me is just kind of where I see us now. And so it's extremely exciting for me to be in this environment where we can come right up to the 1 yard line and try to punch it in. I also have this image in mind. I was recently at the Outer Banks for vacation and visited the Wright Brothers Memorial there. And I took this picture on the left with my phone and tried to make it look old-fashioned. And then I found an even better picture which looks even more old-fashioned on the right. And this is kind of where I see us now in a similar vein. The Wright brothers, they didn't really invent the wing. They didn't invent the internal combustion engine that they used for the propeller. They certainly didn't invent wind and sand. They really were just the guys that built the wind tunnels and tinkered and tinkered and tinkered and tinkered with it until they got it off the ground. And that basically is the moment that I see us in. We're just so close to getting these kinds of therapies off the ground, and it's going to take some tinkering, but that basically is where I put us in terms of getting novel treatments into patients with carcinomatosis. And then, as I had said before, it's important sometimes, often, to acknowledge when we don't have great options for patients, and we don't even have clinical trials to offer patients sometimes. And so any peritoneal surface malignancy program needs to do a very good job of helping patients with coping, helping their family members with providing care, comfort, and getting patients where they need to be when they've reached the end of the disease process where we're just simply unable to help. And so I think that involves another entire army of individuals that we're fortunate to have in our institute, and that would involve things like palliative care, hospice, all kinds of integrative therapies that leverage different parts of or different responses of the body, emotions, et cetera, to help. And that could be aromatherapy or Reiki therapy or massage therapy, and really any number of things. I think, obviously, and I'm going to, I'm sure, forget many vital aspects of our program, but there's just so many ways to help with coping. And I would say this group is probably poster example of something like that, where even the simple act of connecting patients with other people out there, especially with a rare disease, so that they feel less alone and more empowered to get information and to connect with resources. So that's an important foundational guiding principle for us in our program. And then lastly, and I'll leave most of this big picture stuff to Dr. Bartlett, but our program is quickly getting itself off the ground in terms of our team of surgeons. We've had a lot of faculty recruitment activity over the past year with Dr. Bartlett and myself coming. Dr. Edmonds, who was at UPMC as well, has joined our system. And we're very fortunate to have recruited Casey Allen, who's a soon-to-be graduated fellow from MD Anderson Cancer Center. And his expertise is in value-based care and the really big picture questions that I mentioned before. On the other end of the spectrum, maybe than where I would be with molecules and translational work, he sees how this fits into the bigger picture with our healthcare systems and how to make care delivery more efficient and better for patients on sort of a national level. We have begun a fellowship program and are training our first fellow now, and our second one will be arriving next month. We have site visit with ACGME to gain accreditation for our fellowship program, which we anticipate hopefully to have by early next year. And then our hope soon after that would be to develop a peritoneal surface malignancy fellowship, which would be the first of its kind, and to get that off the ground potentially as early as, well, as hopefully before 2023, but at the latest 2023, so that we can really begin to find and hone this environment of innovation and seek like-minded young surgeons to help move these programs forward. So I will leave it at that. I'll say that at our center, we're sort of thinking about these three main pillars of where we need to be excellent, and thinking about where each patient fits into this spectrum, whether it's a standard of care, highly reliable, very state-of-the-art cytoreductive procedure with existing technology in terms of HIPEC, whether that means a clinical trial or an innovative therapy and inventing new types of treatments for this cancer, or whether it means just gathering our arms around patients who we have little to offer in helping with coping and families transition through that process. And I think I'll stop there. I saw a couple of comments and questions which can either be answered now or held till the end. This is just a view of the horizon from where we are, and hoping that all of this promise will translate into action soon.
Great, thank you, Patrick. I think maybe just in case I answer questions during my presentation, we'll go ahead with the presentation, Adele and Chris, if that's all right, and then we'll get questions after that.
Sounds good.
So yeah, I appreciate the presentation from Patrick about the program and really the needs of the program. And now we'll talk a little more specifically about the future. Where do we need to be in 10 years from now, 5 years from now, hopefully sooner than that, with this therapy. And HIPEC has been around for a long time. Really, it started in the early 1980s. And while it hasn't evolved much, I have to say, during that time, and it's, as we talked about, probably helped a lot of patients, but still a lot of room to go. And so, I've thought a lot about what should we be doing, what can we be doing better, and regional therapy and the delivery of agents into the peritoneal cavity. We've really only scratched the surface with the heated chemotherapy, and these are other agents that have been looked at over time. Better chemotherapy delivery using sustained release gels, where you put a gel into the abdominal cavity. Sometimes that can go in as a liquid and then harden and then release chemotherapy over time. So you can, with one treatment, continue to have chemotherapy activity in the abdominal cavity. Nanoparticles are amazing. You can design nanoparticles that can deliver 3 different drugs at 3 different concentrations at a rate that you want. And so the nanoparticle evolution is still going on, and a lot of people are taking advantage of that and looking at that as a way to deliver chemotherapy better to the abdominal cavity. And then pressurized intraperitoneal aerosolized chemotherapy, PIPEC. I know a lot of you have heard about this, and it's kind of in its infancy right now, but has gained a lot of, I would say, popularity at this point in lieu of a lot of data, but something that's out there and that we're going to learn a lot more about over time. In addition, a lot of different agents other than chemotherapy have been delivered into the abdominal cavity. Peptides, so these are small protein fragments that can directly inhibit cancer growth. RNA, this siRNA, these are nucleic acids that can disrupt DNA and RNA in a cell and really target specific protein and knock them down, and that can be delivered directly into the abdominal cavity. Antibodies, so immune proteins that will attach to cancer cells and kill them. PDT, which is a photodynamic therapy where you give a prodrug intravenously that then when you shine a light on the cancer cells die. Cytokines, which are proteins that impact the immune system to bring the immune system in. And I know there's a lot of interest in immunotherapy, and unfortunately, abdominal tumors are notoriously resistant to immune therapies. Now, not every one, but I would say most of the ones that we deal with on a regular basis have no immune signature, and therefore make it very difficult to attack with the immune system. But with novel approaches that we'll talk about some more, we're trying to flip it so that these, what we call cold tumors that are immune, that are not recognized by the immune system, become hot tumors, inflamed tumors that are recognized by the immune system. So cytokines can help with that. CAR T are genetically manipulated immune cells, T cells, that can target cancer cells, and those have been given into the abdominal cavity. TIL, which is tumor infiltrating lymphocytes, where we take the immune cells out of the tumor, activate them in the lab, and give them back to the patients. That has been tried. And then oncolytic viruses, which I'll talk a little more about later. And this is just an exhaustive list that you won't be able to read of all the drugs that have been studied in the peritoneal cavity. So it's kind of amazing that at the end of all this, we are still, using mitomycin C, which has been around since the 1920s. All of these agents have been tried, but they haven't gotten to, the forefront of our clinical use for one reason or another, and we don't have time to go into that. But just know that a lot of different drugs have been tried in the abdominal cavity. And this is a video, if it's working, of what this pressurized intraperitoneal aerosolized chemotherapy is, or PIPEC. And basically, it's taking concentrated chemotherapy, spraying it into the abdominal cavity, and with the hopes that the aerosolized concentrated chemotherapy will kind of penetrate and soak the tumors on the surface and lead to an anti-tumor response. In many ways, it's very similar to HIPEC, except instead of dissolving the chemotherapy in 2 or 3 liters of saline and bathing the insides in a liquid, you're spraying the insides with a little bit of pressure. And I think that gets you a little more concentrated drugs to the tumors, since you don't have 3 liters that you're diluting and circulating. On the other hand, I do worry that it may not actually get and expose itself to all of the agents, because the intestine lays on itself and protects part of the abdominal cavity. And so unless you have the flow of water or saline and kind of manipulation of the abdomen, you may not get all the areas exposed. So there's some pros and cons to this. A lot of people are looking at it, and I think we'll learn more over time. And for 25 years now, which is hard to imagine when your career, when you start to look back on your career, but for 25 years, I've been working on using viruses to kill peritoneal tumors. And I think we're all very in tune to what viruses can do, right? Because of COVID. But viruses are very effective agents at spreading throughout the patients and attacking cells. And if you can trick those viruses to only attack cancer cells, then you have a way that you can use a live virus as a single treatment to kill cancer cells throughout the body. And this is just a schematic of what we're talking about. You can see these viral particles infecting a cancer cell, and within that cancer cell, they reproduce. So hundreds, even thousands of viral particles are released by that cancer cell and go on to infect adjacent cancer cells. However, because we mutate the virus so that it only divides in cancer cells, when it reaches a normal cell represented in X, it won't infect or won't kill that cell. And so these are selective or specific for cancer and resistant in normal cells. So the hope is if you use an aggressive virus, it takes over the body, but only takes over the cancer in the body and not the normal cells. And so you won't get sick with it. And what I've focused my career on is pox viruses. And when this started out, I tried every virus, every way to deliver DNA into cancer cells, from herpes to adenoviruses, the common cold virus, to Rio virus, another cold virus, to some plasmid DNA approaches. So all kinds of viruses. And the one that we had the most success with were pox viruses. And pox viruses, that was, smallpox was the COVID of the 1800s, right? That was the very lethal viral disease. And the reason it's so lethal is within about 4 days, the virus takes over a human body, and really a small inoculum of that virus takes over the whole body, and ultimately a very high mortality rate as the body tries to fight off that virus. But imagine if you take an aggressive virus like smallpox and you mutate it so it only attacks cancer but not normal cells. And that's what I've done over time. We use a cousin of smallpox, a aggressive form of vaccinia virus, and we mutated it by just knocking out some of the proteins that are essential for the virus to kill normal cells, but not essential for the virus to kill cancer cells. And that's a whole process that we won't go into detail. But you have to accept that we've created now a virus that will kill cancer cells, but not normal cells. And it still has all its aggressive characteristics. And so excited about that. And this, just to show you, this was a patient with smallpox, and why I was so interested in vaccinia virus and pox viruses is that this patient had a cat scratch her face, and the pox virus attacked that area of injury. And so although it's going through the bloodstream and going through the entire body, it focused on the area of injury. And in the days of smallpox, patients could write their initials with their fingernail on their skin, and the pox would actually attack it, and they would have pox marks in the form of initials on their body. The point is that the pox virus targets areas of injury, tissue injury, and cancer is a form of tissue injury. And so what we found early on was that if you injected this virus intravenously, it would circulate and target cancer cells and go into cancers and tumors and not into normal tissues. And so doing that, in addition to having it only kill cancer cells, really created a unique virus. And so we've studied this for a long time. And the vision is this, which is treating peritoneal metastases with the virus. And so this is a diagram of us injecting a live virus into the peritoneal cavity. All those little nodules represent tumor. And you can see the virus infecting the tumor, the virus then multiplying within a single tumor nodule, and then being released so that it floats around in the abdominal cavity and attacks the next tumor nodule and other tumor nodules. So it's really the ideal treatment for peritoneal metastases, because it's unlikely if you just fill the belly with a virus that you're gonna infect every cell. But you don't have to. You just have to infect enough cells that the progeny virus or the other viruses will then be released and then spread to the non-infected cells. And then over time, those tumors will disappear, as you see here in this magical diagram. If only it worked this well, we'd all be happy. But that's the goal, is that with the virus replicating as a live virus, delivering it into the abdominal cavity, that will be able to infect all of the tumor within the abdominal cavity. And realizing that it's never just enough to just attack the cancer with a live virus. The beauty of these viral therapies is that you can express genes that can enhance the anti-tumor activity of the virus. So let's say the virus doesn't infect every cancer cells. How do you infect a cell that, or kill a cell that isn't infected by the virus? And what we've been interested in is expressing proteins that allow the immune system to recognize the tumors. And this is what I was talking about, shifting that cold tumor that isn't immune sensitive to a hot tumor that's immune sensitive. And so the virus infects, it kills the cells that it infects. At the same time, it expresses a protein that allows the immune system to attack all the cells around it that didn't get that viral infection. And so this is what we and others have been working on, but this is specifically what I've been working on for a long period of time. And this is just data, and probably more than you need to know, but a recent publication where we designed a new cytokine, which is a unique interleukin cytokine that remains bound to the cell surface that activates the immune system. And we have murine models, so mouse models of carcinomatosis, and everything we do has to go into mouse models to show that it's effective. And so here what we're showing is that this vaccinia expressing this unique novel protein on the surface then goes into the abdominal cavity, infects the cancer cells, induces an immune response. And in this green line here, you can see that the majority of mice live very long time with just a single injection of this virus. And if you don't inject anything, it's a very aggressive model where within 20 to 30 days, the animals succumb to that tumor. We're tripling the median survival, or the survival of those mice, with just a single injection of the virus. And the beauty of this is we can combine it with other agents that we know can impact immune therapy. So you may have heard of checkpoint inhibitors, which are used now in melanoma and lung cancer. There's commercials on TV about asking your doctor. Well, immune checkpoint inhibitors don't work in appendiceal cancer and colon cancer, the majority of colon cancer, and gastric cancer, the kind of cancers that develop in the peritoneal cavity. But once we infect it with the virus and then try the checkpoint inhibitor, it works great. And so 95% of the mice that we treat with this very aggressive model, where without treatment they all die very quickly, 95% are cured when we combine the viral treatments with one of these checkpoint inhibitors. So that's to me is where we are in the future. And this goes one step further, which is after we infect the abdominal cavity with the virus, all of these immune cells go into the abdominal cavity and begin attacking the tumor. What we can do in this study is pull out all of those T cells from the abdominal cavity, and then activate them and give them back to the mice. And those activated T cells then induce an additional immune response and killing of the cancer. The beauty of giving immune cells back is that those immune cells have memory capabilities, which means in theory that if a cancer cell pops up somewhere 5 years later, your immune system is immunized, has T cells that will attack that cancer. And so it prevents those long-term recurrences. So that's why we're very excited about tricking the immune system so that we have that memory response. And I'm going to just spend 5 more minutes, if that's all right, Adele, and then we'll open it up for questions. So the other key aspect of cancer is detecting cancer. And anyone with peritoneal disease knows that. We have to wait until the tumor cells get pretty big or the tumors get pretty big for us to see it on a scan. And yes, we like MRI, maybe it's more sensitive, maybe it's not. We try our best, but there are millions of cells, cancer cells. In order for us to see it on a scan, it takes millions of cancer cells. So, but every cancer, and we're showing it here, every tumor releases dead cells, dead proteins, and dead DNA into the blood. And the techniques are now available to identify and screen the blood for these proteins and this DNA. And this is what you've heard of as liquid biopsies, but the sensitivity of this is really, really moving forward. But imagine if with peritoneal disease, we could pick it up before it shows up. Imagine if we could tell if you were responding to treatment within a week instead of 3 to 6 months that it takes for a scan to change. Then we're not giving you unnecessary treatment. And if the treatment is working, we're taking advantage of that. But we're also picking disease up when it's early, so that PCI score is low, that we're able to remove it and not waiting until it's advanced. So this is an extremely important thing, and something that I've been interested in. We have developed a serial monthly blood sampling on all our patients with peritoneal tumor, so that we're using a very, very, very sensitive technique here, using droplet digital PCR. I don't need to go into it, but it's way more sensitive than PCR, which you already know is very sensitive. So we can amplify any of this tumor DNA that's in the blood and tell whether cancer cells exist in your body. But we need to test it. We need to see exactly how sensitive it is. Is it there for every patient? Is it only certain types of cancers? So this clinical trial is ongoing, and we're excited about that. But in addition to the DNA that we're going to look at by PCR, this is just a smattering of other things. We can look at 1 million proteins that are circulating as a result of that tumor. We can look at your T cell response or your immune cell response to the tumor. All of this stuff, there are literally millions of endpoints that we can look at to try to see how best we can track cancer in your blood. And now we have the machine learning algorithms and artificial intelligence that can put all of this together so that we can really carefully identify these biomarkers and see how you're doing. And this is really where the future is. We shouldn't be giving patients 6 months of chemotherapy to decide if it's working or not. We should be screening patients for cancer, picking it up early and avoiding this. And so this is just a real strong push of what I'm interested in and what we've embarked upon here. We have a genomics lab that's focused on it. We have a proteomics lab that's focused on it. We have Dr. Wagner's pathology lab that's focused on it. We have our electronic medical record that has all of our data discreetly, that will provide us all the kind of tumor information that we need. And then we have this great team of analysts that are just salivating to get on all this data, put it together, and start to spit out some things that we can use clinically. So those are the two things that I'm focused on: better therapies so that we eliminate this problem of peritoneal disease, and better blood tests for screening the existence of cancer so we can treat it early, identify it early, and understand whether patients are responding or not to treatment. So that's what I'm focused on, and I think I will stop there and hopefully have some questions that we can address. And I know we didn't cover everything, but I'm happy to answer specific questions related to this or to anything else that you're interested in.
Okay, Dr. Bartlett, we had a few advanced questions, and I think you did cover a lot of those, but I'll just go through those. So are there any treatment options for patients with late stage metastatic poorly differentiated adenocarcinoma?
So the problem with the advanced high grade tumors, the poorly differentiated tumors, are that from a surgical perspective, that can be beyond what we can treat. And any fast growing tumor, if we try to surgically remove it and we don't get it all, then they can come back very quickly within months. And in some cases, patients haven't even completely recovered from their surgeries and it's coming back. So the high grade tumors are the challenges. And right now we have to rely on intravenous chemotherapy to lessen the burden of disease before we can consider the cytoreductive surgery and HIPEC. And so, and I know that often these tumors become resistant to therapies, but it is important to genomically profile the tumor to see if any unique targets exist. Even RAS mutations nowadays have drugs that we can use to target them. And BRAF mutants have, drugs that can be used to target those mutations. So it's good to know the mutations of the tumor to see if there are agents beyond standard agents that might be applicable. But we really do need those systemic therapy agents to have a response. I think what we're talking about in the trial that we're embarking on is intraperitoneal delivery of the vaccinia virus expressing this modified interleukin-2 with a combination of checkpoint inhibitors will be a trial for those types of patients. And there may be other trials out there like PIPEC trials, like some kind of just serial HIPEC trials where they're just doing laparoscopic HIPEC to see whether or not the disease can respond in that way. So there are some clinical trials, but that's what we're stuck with at this point.
Okay, and along those lines, how does a patient go about getting genetic testing and immunology done to see if they're a candidate for immunotherapy?
So really, if you ask your oncologist or your surgeon, those there are commercial vendors and or the institutions themselves have panels that they can analyze, and they can analyze that on your stored specimen, so you don't need a new biopsy in general. And with these liquid biopsies, in many patients with a blood test, you can also analyze and not have to do a biopsy. So there are what we call liquid biopsies, as well as taking your old tissue from the pathology lab and analyzing it through commercial vendors or through the institution itself. But every oncologist and every surgeon knows how to order that and can order that on your samples.
Okay. How long do these treatments last, and are there side effects, and what can be done to mitigate side effects?
So it depends on what treatment you're talking about. I think if you're talking about investigational agents like immune therapies, and they have very unique side effects. The concern when we're playing with the immune system is that you will induce the immune system to attack your own cells, not just the cancer cells. And when that happens, you can get things like inflammation around the heart, inflammation in the intestines, and some activity against your normal immune cells. So there's some specific, each drug, each kind of new agent, each immunotherapy agent has specific side effects. The beauty of immune therapies, as I said, if we do induce a memory response in your immune cells, that can be long lasting with just a limited amount of treatment. And so with, for instance, the adoptive T cell therapies where we're giving T cells back to patients, that's one treatment, and we're seeing responses that last a lifetime, although it's only been around for 10 or 15 years. So those, and that's not against appendiceal or colon cancers, but against lymphomas and leukemias. So, that's where the real excitement is. A single dose that induces an immune response that lasts, a lifetime. That's kind of the holy grail. We don't have that with these GI cancers, but that's really what we're working towards.
Thank you. There was another question. Could a patient with a PCI of 39 be eligible for surgery?
So and the answer is yes, but a qualified yes, because in patients with low-grade mucinous neoplasms at one extreme, the tumors tend not to be invasive into tissues, and we can take a PCI of 39 and remove all of it. That's a long day. It's a big operation. It's not right for everybody, but that's feasible. In a patient with those poorly differentiated high-grade signet ring cell cancers, that is not possible because the tumor involves and invades and attaches to too many organs, and we just can't get it out. And so it depends on the biology of the tumor. And occasionally we can change that biology with successful intravenous chemotherapy. And so we never shut the door or say no, or it's not possible. But sometimes we have to say, let's see where we can get with the chemotherapy. And if that opens the door for, the surgery and the HIPEC.
Thank you. And right now I'm migrating to the questions in the chat. Are there novel treatments that can break down scar tissue or adhesions, such as training a cell to break that down?
So that's a good question. And unfortunately, that is a huge challenge, as I'm sure many of you know. And we don't have the right answer. The problem is anything that inhibits scar tissue also inhibits healing. And so, and it needs to be given at the time scar tissue is forming. And so, which is right at the time of the operation when you need everything to heal. So it's very challenging to come up with and develop and test agents that inhibit healing. Once it's scarred in, then people have attempted to use different enzymatic or enzymes and proteins that can dissolve and digest scar. But the problem is the targets of those enzymes are proteins that are common to all of our tissue. And so it has too much toxicity. And so I'm not aware of anything promising at this point. I don't know, Patrick, are you aware of anything promising in the clinics to inhibit scar tissue formation or dissolve scar after it exists?
Yeah, well, I'm not sure that I know of anything that works, but there was a clinical trial of a interleukin-6 receptor inhibitor, and in lay terms, that's one of the cytokines, which is a chemical messenger that goes from one set of immune cells to others, and blocking the receptor for that cytokine, which should dampen the immune or the inflammatory response, was shown in an animal model to reduce scar tissue. That hasn't been done in humans yet. But the medication that was used has been given in humans. In fact, it's been given in humans who have had an over-exuberant response to CAR T cells or other immunotherapy agents where they get something called a cytokine release syndrome. And this same medicine just kind of dampens that response. So I think the bigger question, I think Dr. Bartlett already hit on, which is if you do that to dampen the response in terms of scar tissue, are you also going to dampen the response in terms of the immune response to cancers and or, just kind of suppress your immune system when you're trying to heal from an operation, which could also be counterproductive.
For a patient that has had a successful cytoreductive surgery and is on 6-month monitoring, would the oncologic virus therapy be something to consider during that 6-month monitoring?
In the future, with all of these studies, and that's why a lot of these studies don't get across the goal line, as Patrick mentioned, you get up to that first yard line, but pushing it over the goal line into clinical utility is the challenge. And that's where Patrick and I are really focusing. We're going to get it into the goal. So the problem is with these treatments is that getting it getting it to the point of treating it at that stage takes a long time. We first have to prove it's safe. We have to then prove that it's effective against advanced cancer. And then we can move it into that realm where we try to get it to prevent it or give it early at that time, right after surgery, to prevent it from coming back. So that's, unfortunately way down the line in terms of where we can get, but that's kind of the natural evolution, that eventually that's where it would work and it would work best.
Are any of the vaccine trials available yet for humans? And if so, how would someone get enrolled?
So I would say to keep your eyes open for vaccine trials, because they do come available and they go away. And like our trial, which was available for a few years, we completed and went away, and now we're embarking on this new trial, which will take about 6 months to get all our FDA filing, IRB filing, and everything in place. So there is not one that I know of open and available right now, unfortunately. But keep your eyes open and, search the clinical trials websites, and, I think you'll find things open up regularly.
Thank you. What are the pros and cons of the minimally invasive debulking process now in clinical trial?
So, everything we do, for cancer patients, we want to minimize the impact of the surgery, right? Because if it takes you 3 months to recover from a surgery, and it delays you getting other treatments and impacts your quality of life, that's, not worth doing, and it can have a very negative impact. So we want to minimize the impact. So anything we can do with a minimally invasive approach, minimize the impact, enhances the recovery, and then allows you to get more of those. You could get, and be open to more surgeries. The problem is just the extent of disease within the abdominal cavity that limits the ability to do this minimally invasively. And the fact that, in my experience, we need both feel and sight in order to find all the disease. So when we do minimally invasive cytoreductive surgeries, which we will do anytime we can do, I do include a small incision, and this may be more information than you want to know, but I include a small enough incision just to get my hand inside to feel everything. So then I combine the feeling and the seeing to make sure that we're getting all the nodules, because these nodules hide, and sometimes you can't see them, you can only feel them. And so in order to get a complete cytoreduction, that can be the limitation of the minimally invasive approach. But in terms of delivering the chemotherapy, in terms of removing the tumor, all of that, it definitely is a nice approach, and should be considered.
Okay.
If I can add to that, I would just sort of say that where we want to go in the future is with these novel therapies or immune therapies, viral therapies, et cetera, that would be way less invasive in a different sense. So I don't know that we'll ever get there minimally invasive if we think about that in terms of laparoscopy or robotic surgery, et cetera. To think about minimally invasive, we have to think about molecules in the immune system and completely change the nature of the intervention. There's just no way, as Dr. Bartlett said, to really make the surgical intervention of cytoreductive surgery or debulking that much less invasive than it is, which is why we have such a strong motivation to completely turn over the available tools that we have.
Thank you. We do have one of our patients that did go through the virus trial at UCSD, and I'm going to give her the floor now, so maybe she can, and it didn't work for her, but maybe she can talk a little bit about her story and maybe get some additional questions that she has answered. There you go, Melinda.
Hello.
Hi.
Hi. spent last November, December, and part of January, February at, but we did the oncolic virus. They killed my immune system and then inserted the cold virus into my belly. And I did that for like 6 weeks, along with some kind of a chemotherapy. Unfortunately, when they did the last laparoscope and it was completed, the tumors had grown and the trial did not produce any. It was supposed to go in and explode the tumors, and then the pieces would go around and get all the other tumors. So, and I was an excellent candidate. Have you had success? The other person that was in it that he knew of, she ended back on chemo, which I am too. So they hadn't had much success, but there was one success back in New York. Have you had any information, any feedback that this actually has worked? Because I don't know, maybe they did something wrong, or, you know, if I need to maybe go back and do it again or whatever.
So, you know, I appreciate your being involved in that trial and going through that. And, you know, it is exciting that they're moving this forward. A couple of observations. One is, you know, unfortunately, the reality is with clinical trials that they're going to not work more often than they're going to work. But the, you know, the real heroes are, you know, those like yourself that are willing to embark on these clinical trials without really knowing what the side effects are and what the, you know, opportunities are. And, you know, I do remind patients that, you know, they're not undergoing treatment within the clinical trial so much to help themselves, but to help the next people. And so, you know, what we're doing and what they're doing with the trials is learning. They're learning why you didn't respond and what do they have to do better the next time. And, you know, their virus is different than our virus. Their delivery is different. I mean, every trial is different. And until we start to see those successes and focus on what's successful with the treatments, you know, we're not going to know how to move forward. So, so it is a frustrating process for us as investigators. And, you know, the same thing with what you received as what we're using, where, you know, we're curing mice left and right, you know, but moving it into the patients is what we're talking about, what Patrick was talking about, getting it over that goal line to clinical utility. That's where we've been blocked, and that's where we need to push through. But it does require participation in clinical trials as you've done. But I can't say that they, you know, used the wrong virus, or they used the wrong dose, or they needed to give you 5 doses instead of 1 dose. All of those things are the questions that they'll be asking when they look at the results of the trial, and others will be asking when they publish the results of those trials. So it informs us how to move forward the next time better. And so it is the nature of trials that they're not likely to work, you know, the first time they're being tried. But, you know, I would encourage everyone to be involved. And, you know, again, it's a heroic effort to do something like that so that you can help others in the future.
Yeah, it was kind of brutal. It caused a lot of rigors, the bad shaking and stuff, and kind of wore me down. But Dr. Patel was extremely disappointed because they really had high hopes that I was going to go for it, and we don't know. But that's what I told them. At least you'll be able to figure out why it didn't work from my test, because boy, you take a lot of blood, bottles and bottles of it. So I said, at least they'll be able to figure out why it didn't do what it was doing. And they didn't inject it into the tumors. They just injected it into the belly, and it was supposed to do kind of a search and destroy kind of method. And maybe that you were talking about inserting it into the tumors. Maybe that's the key there. So, and it was stage 2 of the trial is what I was in.
Yeah. Okay.
So.
Yeah. As you can imagine, just a lot of questions as to why it didn't work, and then, addressing that for the next trial. But that's why these studies are challenging. But, when we do see it effective, then it's important to have all that data to really try to define what we did right and reproduce it.
I still am monitored by him. He calls me once every couple months and we go over things. I don't know, do you guys share information like that? Because maybe he'd have some stuff that could help you or vice versa.
Absolutely, yes. And I have not shared anything directly with him, but yes, through that regional cancer therapies meetings where we kind of present all new clinical trials, that's an opportunity for us to kind of recognize what other people are doing, have those active discussions, and help each other out. And I would say that it's a very, very collaborative group of investigators with this disease. We are all touched by what patients are going through and really looking to work together to find the answers. So I found it to be a very collaborative group in that way.
Great. Thank you very much.
Thank you. There were a couple of questions, Dr. Wagner. You referenced an 833 number in your presentation, and not everyone caught that. Could you repeat that?
Sure. Actually, I can just put it in the chat now if you'd like, but it's 833. I was just typing a message to the patient. I didn't catch her name. I'm sorry, that just spoke, thanking her for her willingness to encourage and engaging in the trial. I'm typing now, but it's 833 AHNSONC.
Thank you. Another comment you made related to going through records. I mean, do you have any tips for patients in accumulating their histories and streamlining it? And in that, from a patient perspective, that's a frustration, because getting our records and getting them sent to the right hands in the format that you need. So any tips you can provide would be helpful.
Yeah.
Sorry. Go ahead.
No, I was just going to say, number one, they're your property. So if your records are your property, and it always drives me crazy that hospitals are even allowed to charge patients to give them, to print out their records or something of that nature. So I would say, you just sort of have to sometimes be a little, just stand your ground. They're your property, and you have every right to have every bit of it sent. The issue with the modern electronic medical record is that it's often just a mountain of paperwork to transmit a small amount of information when it's printed out or transferred in that way. So we have a very aggressive team that doesn't take no for an answer when it comes to giving. When we hear from patients, we won't rest until we have the information we need, and that involves a lot of phone calls on our side to get things sent and advocate for patients in that way. At the end of the day, we have a team behind the scenes that we obviously we're stretched for time, so we need our PAs and our nursing staff who are extremely experienced in this and very skilled. They pore over the charts and kind of distill it into the amount of information that can be processed in an hour-long visit, let's say. So they're always willing, and so are we, to communicate with patients by phone. Sometimes it's easiest just to get on the phone and kind of talk through it. That saves us a lot of time rather than just poring over the records. And so I would just sort of encourage individuals to seek out providers that are willing to take the time to just talk on the phone for a few minutes or have a video call, because you can learn a lot more in 20 minutes of that than you can by sitting staring at a mountain of paperwork.
What hospital information system do you guys have there? Is it Epic or Cerner, or what is it?
We have Epic, and many, as you probably know, many institutions can share their records directly through Epic. So that does speed things up a bit.
Patrick?
Yes.
A question for you on that. Will the as far as the records, would it help in the future if AHN develops some type of checklist or matrix? If you're if it's this type of cancer you have, we need this, and this to help them guide what records are sent. Because like I said, I'm sure there's different versions, different readers for different types of data. But maybe a suggestion you guys could think about.
Yeah, that's a really great thought, and we'd have to obviously put a lot of thought into it. And you can imagine that, the most recent CAT scan, for example, is more important than, let's say, one from 10 years ago, even though they're all important. Some are more important than others. And sometimes, and everybody on this line knows that the situation is so unique. Every patient with this type of cancer is so unique that it's very hard to make even a checklist, although you could certainly get the basics on it, but even so, it's really individualized. So I think the combination of kind of a template checklist along with a careful review by a human on the other side of that who's just trying to help you, just kind of get what you need, and someone that knows what the surgeon or the doctors are going to need on the other end of that.
Right. I mean, it could be simple as, certain, if you can only read a certain system to understand how it needs to be output or how it's going to come in outputted. So it's a 3, 4, 5 day process to get files to you, but it could mean 10 days if you have to go back and get the right output from another hospital system. So
yeah, I think these systems are supposed to be able to talk with one another, and even though that's way over my head, it's not over everybody's head. So there should be IT experts in our network and between Highmark and AHN to realize the actual promise of the electronic medical record, which was to make this easier, not harder. So that you're not printing 1,000 pages out of one system and then scanning them into the next system as media files, which is kind of what happens now. It's crazy.
Okay. Thank you.
Yeah,
Yes,
that was a great thought.
We do need to look at scans, and I think that's often an issue where patients will send a fax of the report, but we actually need to look at the scan. So that becomes sometimes challenging, but we can always get those on discs from the institutions and have them sent for us to look at.
Dr. Burrow, does if I understand from Patrick correctly, can everybody read when you say scan? If someone says you need a CAT scan to look at, is there different output methods from the sending side? Because I'm in the automotive industry, so we have to output data in certain ways so that the next person can read it and not delay the process. So it can be as simple as that, just defining I need it in .doc format or .step format. So maybe that saves time.
Yeah, for the most part, that communication does occur, and we can open almost any file, and it seems to be specific to the institution as to what file they send it in, but we can open it.
Okay, perfect.
Joanna, would you like to ask a question?
I do. I actually have two very basic questions for Dr. Bartlett and Dr. Wagner. I am newly diagnosed. I was diagnosed in February, and I am just starting chemotherapy, so I'm very early on in my journey, but I wondered if, first and foremost, if Dr. Bartlett, and apologies if I'm not paraphrasing this correctly, if you could elaborate on something that you mentioned when you opened, and that peritoneal tumors are some of the most challenging cancers to diagnose or to work with. I'm wondering if you could elaborate on that a little bit. And then my second question is, if you could both talk about the role of the omentum in your peritoneal cavity. It seems that it's something that your appendix cancer really likes, but we don't really quite know what it is, or at least that's what my surgeon initially explained to me, that they still don't quite know what the omentum quite serves within the cavity. So
I'll let Patrick answer the second one, and I'll just answer the first one since that was my comment. I think these tumors are difficult because they're difficult to image. It's hard to know that they're there for sure. They're difficult because they can cause complications within the abdominal cavity, like bowel obstruction. And they're difficult because those symptoms are some of the, can be very painful and uncomfortable and, challenging to live with. And so it's just, when we look at other types of cancer, it's just the one that people are the most uncomfortable treating and just a challenge. And Patrick, I'll let you answer the omentum.
Yes. So the omentum is really just kind of a hanging blob of fatty tissue. I don't think I've ever heard a satisfactory explanation for why we have it or what it does. It probably protects some of the abdominal organs from contact in some ways, but it's just sort of a drape of fatty tissue. It may store, may have a role in storing energy that is subsequently released during, if you imagine during evolution, periods of starvation or what have you, that it just kind of is a place where your body can store extra fatty molecules and then burn them later. So that's what it is. It has a large surface area, which I think probably is one reason why it disproportionately sort of attracts cancer cells. I don't know that we know that there's a magnetism, so to speak, or a chemical signal, although that does happen in other areas where if growth factors, for instance, which are little hormones that are secreted and signal from one cell to another, if those are secreted by one tissue, cancers can kind of gravitate to them, similar to the way Dr. Bartlett described with the cat scratch and the smallpox and the virus going and kind of landing preferentially there. So it's a mystery. In a sense, it's a good thing because it's very straightforward to remove the omentum, and you're not really removing an organ. So when you have tumor in the omentum, it's generally easily removed. And doesn't really cause any side effects, or it's certainly not like losing a part of the intestines or the stomach or the colon. So I hope that answers your questions about the omentum. Yeah, okay.
Do other abdominal tumors tend to prefer the omentum as well, like ovarian and gastric?
Yes. Okay. It's even got a term which I never really understood completely, but we call it caking of the omentum or an omental cake, which I don't know what it is about pathologists, but they always try to compare things to food. So when they describe tissues or tumors or processes, there's always some reference to food. And that's one of those examples. But it's very common for many types of cancer in the abdominal cavity.
You probably see a couple other questions in the chat. Does the omentum grow back once it's gone?
No, it would be nice if it did, because we use it for other things and other scenarios, like to wrap patches around organs that are damaged or injured, or to take up space when we've had to remove an area. So it doesn't grow back though.
And then can you speak to cocooning? The other question in the chat here.
Cocooning?
Yeah, I'm reading the question that just came in the chat. Cocooning.
I think that, what that refers to is the scar tissue problem, where cancers either induce scar tissue themselves or scar tissue from the prior surgeries then kind of protect or cocoon tumor nodules. And that can make it a challenge to target those nodules if you're putting in chemotherapy into the abdominal cavity, for instance. So and that gets us back to it'd be beautiful to be able to dissolve scar tissue without dissolving tissue, and right now we just can't do that. So we do have to, when we go back in to deal with the cancer, have to divide all that scar tissue, remove all that tissue in order to see everything and expose the areas.
Thank you. And back to the omentum, can it be removed by laparoscope?
Yes, it can be disconnected and removed. If it's got a lot of tumor in it, we may have to make a slightly bigger incision just to extract it at the very end, but yeah, it can be removed. If that's the only thing that we have to remove, then we would probably take something like that on minimally invasive laparoscopically. It's just seldom the only area that there's tumor. It is often the dominant area, but it is seldom the only area.
How about peritoneal stripping? I understand sometimes we have to strip the entire lining because that's just the easiest approach. That doesn't grow back. You can't do that successively, can you?
Well, that does grow back actually.
Okay.
So like you mentioned, sometimes it's easier and safest just to kind of get into the plane and separate the entire peritoneum from the underlying tissues rather than doing tumor by tumor by tumor by tumor nodule. You just kind of get into the plane in between the two. It's almost sort of like taking old wallpaper off. It just kind of peels off, but it does grow back. And that is almost like when you have a rug burn or something on your skin. The edges, it grows from the edges that eventually they'll meet.
Nice.
So the peritoneum does grow back. Yes.
Thank you.
And then does removing the omentum cause someone's abdomen to be uneven?
Not usually. The unevenness typically comes from either removing parts of the actual muscles and tendons of the abdominal wall or removing the skin, or sometimes if we've had to make a colostomy, it's never symmetric. Even if we haven't removed anything, the process, when we open the muscles and tendons to open the abdomen, when we close it back up, we use big, heavy sutures that gather the tissues together, and it's not the flat surface that you were born with. It's kind of gathered and together, which makes things certainly lumpy, and it's never perfectly symmetric. So it's just something it's irreversible. It's not, it was nice and flat before, but it'll never be, once we open. And that's true of any surgical scar, some worse than others.
You both talked about all the effort it takes to get the studies and the trials over the finish line. That being said, is there some sort of projected timeline that you're hoping for?
We're working on it, I would say, day and night. So I would think in our institution, my personal goal is by the end of the summer to have at least, and like I think I had indicated that we have several trials off the ground now that are kind of baseline studies, things that we need to be collecting tissues, tumor specimens, and immune profiling. We're already collecting blood for circulating tumor DNA and measuring that before and after debulking surgeries and chemotherapy. In terms of novel interventions, I would say we're months away, and it's hard to put a finer point on it than that because many of these agents have to be acquired from pharmaceutical companies. And there's a lot of supply chain issues right now, and just a lot of factors there. And then in terms of something like a viral therapy, there's very, very few facilities around that can make a grade of virus that can be given to a human as a medical intervention. And we are building one of those, but you can imagine the regulatory background of that. So I would say it's measured in months, but I don't think our first trials will be I think that's months until we have our first kind of battery of trials up. At the end of the day, my part of this is to get, especially with the viruses. Dr. Bartlett's been making viruses for decades, and his lab will probably be, active in designing them and getting the next one ready. And my job is to get it into, whichever one we're working on currently into patients and help study, and he has promised to keep one virus ahead of me. So that is kind of the vision that we have, hopefully within months or by the end of the year, that we have something we can start with.
Thank you. We had a patient with a recent CRS HIPEC. Their falciform ligament was removed. Does that have any lasting effect, and what's the function of that?
Similar to the omentum, it actually had, the falciform ligament does have a function. It's just, it is in the embryonic and fetal stage. It's the umbilical, the inside of the umbilical cord. It just keeps going through your abdominal wall and belly button. And then on the other side, it becomes the falciform ligament, which goes through your liver and into the main blood vessel, the main vein of the body. That's to allow the placental blood to enter a fetus and get into the circulation. Once the umbilical cord is cut, it loses its circulatory flow and it just becomes a ligament. So there is no lasting effect of having the falciform ligament removed. It's basically at that point just a relic of fetal life, at which time it was very important, but in the adult it serves no function.
Thank you. Well, I think we're a little over time. We probably only have time for another question or two if somebody wants to raise their hand and has another question. Otherwise, we'll go to our closing comments.
Oh, I'm gonna take the floor on that one because I do have one question. I think there's been a lot of interest in Professor Morris's work with the digestive enzymes and Bromac. Do you see that as part of the problem, part of the challenge? The mucus protecting some of those scant cells that are floating around. Do you see a role for those enzymes and that Bromac approach being helpful in the future as we look at these different integrative approaches?
Yeah, and a lot of times it's not the tumor cells themselves, but the mucin produced by the tumor cells that really creates all the problems that we have. And you can't just pull it out with a needle because it's too thick. So you need to liquefy it first. And so these enzymatic approaches make sense to try to liquefy the mucin, because then you could just, lavage or just, suck it out, and, a lot of the impact of that would go away. I think what he's finding and what we found in the laboratory using similar enzyme approaches is that we can't get access to the mucin because the scar tissue surrounds the mucin, and it gets us back to, we have to be able to dissolve the scar tissue and the mucin. And so the technique works very well to liquefy mucin in a tube, but not very well to do it in the body, and that's because the body reacts to the mucin and forms scar around it. So it's important research and important clinical trials, and like everything that we talked about, we're going to learn from those trials and hopefully have a better next trial. But I definitely think that's an important area of research.
Great.
Okay, we have a patient that has a pathology of signet cell, undifferentiated and unknown primary. And because of that unknown primary, they're having a hard time getting into trials because trials typically want a primary. So are you aware of any trials this patient could be into, or any tips for how this patient could get into some trials?
There are a number of clinical trials that don't designate a specific histology. Generally, those are phase 1 trials where drugs are being tried for the first time. And there are trials now, which are called basket trials, where the genomic profile of the tumor indicates the treatment, not the tissue that it came from. So I think both of those are important. I would say anybody with appendiceal cancer has the same problem, because appendiceal cancer is really never defined in a clinical trial for new agents, because it's just too rare of a cancer. So I think you just have to seek out trials that are not specific to histology, but are either early phase trials or specific to gene abnormalities that exist within the tumor.
What can we patients do to help you in your trials? If we have patients that are offering to share their blood samples or tissue samples, is there anything we can do to help?
Well, I think that's exactly what what we can always use help with is enrolling in our clinical trials and other clinical trials, and I think that's key. Obviously, also, the financial aspect of things, everybody that has a research program is limited most by finances. That's the reality of it. You know, we can apply for grants. That takes a year in process, and then the grants don't really cover all the clinical trial needs. So we're constantly, you know, in fundraising mode to support trials and support research. So, you know, those are the kind of things that you can help with. The advocacy, you know, I think is extremely important, which is what PMP PALS does so well. And then just spreading the knowledge that, you know, as a clinical trial opens, that it's there and, you know, allows patients to seek it out and be enrolled.
Thank you. Well, we are at time, and so I will take a moment to share my screen one more time. So just a reminder of all the programs we have here at PMP PALS. We have these Hope Zoom calls. We have them twice a week now, typically Saturdays at 11 a.m. Eastern and Tuesdays at 3:30 p.m. Eastern. About once a month, we have guest presenters like we did today. One of our longtime programs is our Bare Bottom Bears program. So please, if you're a patient, sign up to get a bear. Nothing brings more joy to a patient when you're going through your treatment than a reminder that you're not alone. Any questions at any time, send an email to info@pmppals.net and we will get those questions answered. Also feel free to use our Ask Arthur feature. Arthur is a patient and a retired pediatric surgeon, and he's there to help interpret some more clinical and medical terms. Our Get Well card program, or our card program, our most popular program, goes all the way back to something that our founder, Gabriella Graham, started, but sending cards or receiving cards when you need them most as you're going through treatment, recovering from surgery. And there's nothing more uplifting than getting cards from patients around the world. And then sign up to get a PMP PALS starter kits with all kinds of goodies that you might need as a patient. You know, hand sanitizer, notes, notebooks, things like that. You know, again, we do have hope for you, and we hope you'll continue to stay in touch with us throughout the week, again, through our website, pmppals.net, our Facebook page, and our Instagram. And so with that, Dr. Bartlett, Dr. Wagner, we can't thank you enough for your awesome presentation and the time that you've spent with us today.
Yeah, thank you for having us. We appreciate
Thank you.
Appreciate everybody's hanging in there.
Thank you. All right, bye everybody.
Thanks so much, everyone. Have a great week.